that I am a NRI faculty of ASTA CG Ahmedabad, not receiving any honorarium also. I thank Kaustubh, I thank Rajan, I thank Aditya, I thank Nitin, I thank Dushan, and I have given so many people so many thanks, thinking that they will allow me 5 minutes more, you know. The lymph node metastasis is depending upon the availability of the lymphatics, biology of cancer. Thyroid is the best model. Occurring in the same organ, biologically different thyroid cancers have different nodal metastasis, and therefore stage of the disease, as far as thyroid is concerned, T is not equivalent to N, and of course previous treatment will change. Now, lymphatic pathways follow the vascular channels. Inferior thyroid artery and superior thyroid artery are the principal arteries, and they originate from thyrocervical trunk, the inferior thyroid artery, but there is a big difference between right thyrocervical trunk, which is given by subclavian, at the innominate junction, which is at the lateral and slightly higher, so you can have a retrojugular node. As far as left is concerned, it is given directly by subclavian, and you can have infraclavicular. So it is important to understand the difference. Central compartment is the primary echelon. Level 4, 5, 7, all are, and retrojugular node are not exactly in the neck, and therefore we should understand the difference in lymphatic pattern. And thyroid also have intraglandular lymphatics. Now, it is very important that you understand this diagram, where it is very clearly seen that the inferior thyroid artery has a particular relationship with not only the recurrent nerve, the parathyroids, and you see all these pictures are mostly taken by ward boys or sisters or something like that, using whatever camera they had. And this is unedited picture completely. I would be very happy if these lights are put off. They don't need to see my face. And it is important that we realize that whatever subtle differences Arvind has told, there is a consensus that we have good thyroid cancers, bad thyroid cancers, and now we are going to discuss on low risk DTC. The general philosophy is very simple. Low, intermediate, and high risk categories, they dictate the attitude towards the primary. Irrespective of the risk category, nodal metastasis is treated on its own merit. Occult and clinical nodal mets are very common in young children. Should nodal mets change our philosophy towards the primary? I think that should be a very important issue to be discussed. That suppose you have a low risk cancer, but you have lymph node metastasis, will you change? And the primary in low risk individuals, that is the important issue. Now, relevance of nodal metastasis, presence of nodal metastasis has no prognostic significance, at least in low-risk DTC. In fact, Black Lady 1,000 years ago thought it to be a synchronon of good prognosis. He has a paper on that. Nodal metastasis may be the only presenting symptom. Surgery is the preferred modality, and these nodes from thyroid cancer have rarely ECR, they are discrete, and no oblong surgery is possible. Prognostic significance of low risk, what are the groups which are at risk? Should we resort to elective central compartment? What is an ideal procedure? Why routine IGV exploration is inadequate, particularly on the right side. If you see, the nodes are retrojugular because the inferior thyroid artery comes from subclavian there, and therefore we need to understand that. And should we do an ipsilateral versus comprehensive bilateral? Should we achieve cure versus control? Now, it is very important that irrespective of anything, if you are doing cancer surgery, you are going to address primary echelon, and in that sense, thyroid surgery is nothing but identification, dissection, and preservation of parathyroid. And you see, only in this organ, you can see 3 different colors. You see parathyroid very nicely, you see fat, and you see that blue little tiny dot, which is a paratracheal lymph node. And therefore, it is very important that you understand that if we are going to do a paratracheal clearance, which is a primary surgery, ipsilateral, we need to take into account these facts. What is the location? And you see in this case, there is a parathyroid which is literally chip code to the thyroid. Now, irrespective of anything, this parathyroid cannot be saved in situ without using microscopes or things like that, and probably will need implantation. So it is very important that we realize parathyroid locations are very, very different from everything, and you will know that all of us are doing total thyroidectomies and lobectomies, but all of us don't have so high incidence of parathyroid deficiency, maybe because the location is very difficult. Now, it is important that we understand that preservation of vascularized parathyroid in situ after a good paratracheal clearance is not so easy. We need to identify, should we use eyes? Should we use a microscope? There are no microscope has been used in this, no fancy gadgets were used. We should confirm it by further section before you implant. And now we need to understand, as Arvind was telling, should we stop at that level and leave entire paratracheal tissue in place in good thyroid cancer and avoid complication? Or should we resort to this ipsilateral paratracheal clearance bearing the entire recurrent laryngeal nerve from its entry into the neck to the entry into the larynx and see entire paratracheal groove? Or should we do this kind of a resection where we see common carotid to common carotid, we see common carotid on the right becoming ruminant artery and things like that, and mind you, in spite of this kind of a clearance, your nuclear nanny is going to tell that thyroid tissue is remaining somewhere. I don't know from where they get that thyroid tissue. Once I was told this, then I sent this picture to him and told him that please tell me where is the thyroid tissue. Anyway, so we need to understand, and this is a very, very important slide from Dr. Shah, Ashok Shah. Management should achieve the clinical balance between our best estimates of aggressiveness of the disease and the effectiveness of our treatment and its possible complication. And that is the crux of the matter. What are the clinical situations? We have neck node, MUO, most common presentation, synchronous nodule with neck node, which is malignant, preoperative during benign surgery, occult. Remember, differentiated thyroid cancer is the commonest subclinical cancer. 50% of us may be having that. And of course, you can have metaclonus lymph node metastasis after a good treatment of low risk cancer. Now, it is very important that we understand that we have unconfirmed, we have confirmed cancer, we have surprise cancer, and therefore we will have to be vigilant when we are treating a low risk DTC, and that is the important thing. These are the clinical situations I have already told: MUO, synchronous, peroperative, metaclonus. And this is a scenario where I was called by a junior person, and he was telling, sir, something blue is coming. He was doing a lymph node biopsy in the posterior triangle, and bluish lymph node is symptom of thyroid metastasis. This is another MUO level 4. And we should realize that therapeutic modified neck dissection is an ideal procedure for differentiated thyroid cancer. Level 5 is not a principal catchment area, no soft tissue continuity with neck, non-confluent neck metastasis, they are discrete, extracapsular invasion is very rare, lack of soft tissue deposits. So this makes this procedure as an ideal operation, and as we know, battle of thyroid is lost in the mediastinum and not in lateral neck. Modified type 3 dissection in progress, and you see that we will have to do in this case particularly paratracheal clearance, which is done. Another MUO. Now this is at the posterior triangle. This lady had a very small tumor, and we continue to do this. The nodes kept on coming with this huge node. I thought this is the end of it, but to my surprise, as it was on the left side, the level of this node will be at the level of subclavian giving rise to thyrocervical trunk, and you see this deposit is literally came from below the clavicle, so you should be very careful. There is a difference between right-sided neck disease or retrojugular as compared to the left. The left, you have to really go down and you may get the disease there, and therefore you have to clear This is another case in point. You see, this is the thing, and you, just 2 minutes, and you see the disease coming below the clavicle. Sometimes you have stage nodes at Delphian node. You can see this separate thing, and this will require separate kind of a treatment. It's a low-risk cancer, and in that particular case, you will have to do a good paratracheal clearance, and this is the established cancer where there is no doubt you will have to do a good paratracheal clearance. You can see very nicely that everything is being shown. You see that is the Doris ligament tissue, which is usually reported and pyramidal lobe by our nuclear colleagues, showing residual thyroid, and that is what. Last slide. It is possible that in a differentiated thyroid cancer with a lymph node metastasis treated, over the years, that lymph node metastasis may get de-differentiated, and here is the disease which got de-differentiated, and we literally had to do this kind of extended radical leg dissection, and therefore it is very important. This is not included in my time. It is continuation of the talk which Arvind gave and the question which Gauri Pantabadya asked. Now, try to understand that we have two so-called parallel line, but there is a slight difference between them. So, if you go 1,000 and 1,000 and 1,000 kilometers, at one time they will look divergent. I personally feel that this problem of thyroid is happening because better and better and better thyroid primary control is taking place. Patients are living longer and longer and longer, and therefore even an innocuous cancer, today, tomorrow, 1 month later, 1 decade later, 100 years later, will make you understand that this could have killed. As Pierre Danva, the inventor of TNM, told in one of his lectures that actually the moment you have invasive cancer, it is incurable. Thank you very much for the podium. I really enjoyed speaking to this kind of audience. I see everybody here, a thyroid surgeon, I see general surgeon, I see head and neck surgeon, I see ENT surgeons. I once again congratulate Kaustubh, Rajan and the entire team for putting this beautiful show with hospitality, with cordiality. It is not just a show of their excellence or their infrastructure. Thank you so much.